Larry Bauer, Chief Executive Officer of the Family Medicine Education Consortium, and we're excited tonight to have faculty from the Virginia Commonwealth University Fairfax Family Medicine Residency Program leading this session. So I'm going to turn it over to Dr. Ho and Dr. Crutchfield. Take it away.
All right, thanks a lot, Larry. I am going to go ahead and share my screen, and then hopefully we'll be able to get started. Okay, hopefully.
Nope, not here.
All right, so can you guys see my slides? Can I get a video? Perfect. Okay.
Yep, looks good.
We can see them.
Perfect. All right. Well, so I'm Gary Ho. I'm the program director for the Sports Medicine Fellowship at Fairfax Family Practice, VCU, and one of the core faculty at the Family Medicine Residency. And I'm also joined by our newest faculty member, Anna Crutchfield, who comes to us with a good amount of experience in point-of-care ultrasound. I've been doing musculoskeletal ultrasound since 2007 with non-musculoskeletal point-of-care ultrasound, or POCUS for short, since 2012. And Anna's had a good amount of experience throughout her residency and fellowship with this as well. So hopefully between the two of us, we'll have a nice and informative talk. I think our goal is to do some introductions, some just introductory concepts, maybe a little bit, tiny bit of physics and nuts and bolts when it comes to those that are relevant for point-of-care ultrasound in the primary care setting. And then we'll talk a little bit about some examples of where point-of-care ultrasound, or POCUS, has been used in our clinic, real patient encounters, where it's been used to enhance the patient experience and outcomes. Hopefully we'll have some time at the end for some Q&A and be able to have some good discussion, okay? So without further ado, I will kick it off. So no discussion of any kind of new technology, especially one that is likely to have a profound impact on how we do our work with patients day to day, would be complete without mentioning the disruptive nature of said technology. So of course, things that are new tend to often are met with a lot of excitement, but sometimes a little trepidation too, as we try to figure out, well, what is useful, what is likely to enhance our ability to reach the outcomes that we want, versus what type of new technology might be disruptive, but not in a good way, perhaps increasing our work and actually creating barriers for providing care. I mean, great examples of that could be our EMR. You know, I think when electronic records first came out, there was a lot of excitement for the potential for it, but very rapidly we could see how that disruptive nature may actually sometimes cause barriers. And so here's just a definition from Wikipedia as to what might be considered a disruptive technology. And that would be, you know, some sort of technological innovation that kind of utilizes or represents a disruptive strategy that, rather than a revolutionary strategy, that essentially overturns existing dominant processes and the status quo. And so for a moment, let's consider the following quote that was used to apply to a type of disruptive technology in medicine. And I will read this quote. It says, "That it will ever come into general use, notwithstanding its value, is extremely doubtful, because its beneficial application requires much time and gives a good bit of trouble both to the patient and the practitioner, because its hue and character are foreign and opposed to all our habits and associations." Now, you may or may not have heard this before, but I know the first time I read this, I was particularly surprised to hear that this quote was applied to the stethoscope. And of course, nowadays, I think we can safely consider the stethoscope to be fairly ubiquitous when it comes to physical diagnosis. I mean, it's almost become a symbol of our field. And you can imagine the medical students first time when they get their stethoscope, the kind of excitement they have as they enter into our profession. So you know, I think that with enough time and enough support, even new technologies that are met with trepidation have the potential to really enhance what we do day to day. So for a moment, consider, you know, what we're using it for. You know, I think that, you know, I think the best place for ultrasound at the point of care really is meant to enhance what we already do. You know, of course, in medical school, and I spent a lot of time teaching medical students, we talk about getting a differential diagnosis when we approach our patients, using history to further narrow that down, physical exam to further narrow down that long list of differential diagnoses in order to find bits of information, both in the history and physical exam maneuvers and certain techniques, in order to come to a working diagnosis, excluding some possibilities, increasing the likelihood of others, so that we can actually arrive into something that's helpful for us to act upon in order to treat our patients. As such, we frequently use these maneuvers or elements of the history to answer key clinical questions. And all of this gets factored into this vague concept of clinical acumen that we wield in order to take the best care of our patient. But as we've already demonstrated with the stethoscope and other tools, such as the reflex hammer, or the ophthalmoscope, or the otoscope, we use technology and tools in order to help us better answer these questions, in order to facilitate what is really the best tool, which is between our ears. But it wouldn't it be nice to be able to look inside our patients to further answer some of these questions? That is where I think POCUS, or point of care ultrasound, lives. You know, I think we need to move away from thinking of ultrasonology or sonography as a standalone laboratory or diagnostic imaging test, but rather a tool that has rapidly become something that fits readily in our hands. It can fit in our white coat pockets, and basically become a tool that we can use to extend our physical exam, to improve our physical diagnosis, answer clinical questions at the point of care in order for us to provide care for our patients in the exam room as soon as we are assessing them. So why point of care ultrasound, and why now? And how has ultrasound, you know, kind of been able to be ready for prime time in primary care? And I think that there's multiple different reasons why this has happened. And one is the rapidly advancing and developing technology. With newer technology and chips, microchip designs, computers, mobile devices, ultrasound technology has become more and more miniaturized, along with all the other stuff that we techies like to play with, such that now the portability and, quite frankly, the affordability has reached a point that it's very viable and very accessible to the practicing clinician. And so, you know, that is one reason why now is the time to consider adopting it. The other is that as more and more ultrasound has reached the hands of bedside clinicians or clinicians in the outpatient office, we've learned to develop newer techniques that allow us to make the utility of point of care ultrasound and the teaching of point of care ultrasound much easier, and therefore much more approachable. And really, we're getting to the point where we're going to demystify the difficulties that people may encounter when they initially learn how to use new technologies such as ultrasound. Ultrasound, you know, has been shown to be have great utility when it comes to helping to provide assurance for guiding procedures. But I want to take point of care ultrasound in our discussion beyond guidance of procedures, such as placing central lines and things like that, which we've known for a long time that ultrasound can be very helpful. What we want to do is basically take ultrasound away from that and move it more towards the tool that you can use for your physical diagnosis. So one of the biggest challenges that I come across when I teach point of care ultrasound to family physicians and other primary care providers is there's often this feeling that it's a very daunting set of skills to learn. But if you look at some of the literature, there's actually pretty good data that suggests that in the right setting, point-of-care ultrasound can be learned fairly easily. Paul Borneman and his colleagues published a feasibility study in 2014 looking at POCUS training in family medicine faculty and residents. And what he did was they looked at 16 hours of training, and this is more in general senses, but the family docs reported that POCUS was easy to learn. It improved diagnostic efficiency and accuracy at the office in the point of care, and 86% of the faculty and residents in family medicine agreed or strongly agreed that they would use POCUS again. This next study I found to be particularly entertaining, and this was a study by Kwan and his colleagues published just this past year in 2019, looking at POCUS training and image acquisition in 8th graders. And what they did was it took a cohort of 8th graders and trained them to do the FAST exam. And what you could see is that if you look at the FAST exam, most of the exam acoustic windows were pretty easily attained. Now, I would argue that the subxiphoid cardiac percentage of adequacy rate was low, but cardiac is probably among the hardest of POCUS applications to learn. And I think that just spending 2 hours learning cardiac may not be enough. But outside of cardiac, I think that you could see that the percentages of adequacy as assessed by an experienced sonographer was fairly high, and that most 8th graders were able to obtain clinically adequate images for the FAST exam with just 2 hours of training. So this next slide just kind of shows just a quick little list of different things that I've used in the office and on inpatient rounds to actually answer clinical questions that have actually changed our decision making at the point of care. And we'll go over some of these in our examples. But I think I do want to kind of reiterate that I think the way to best use POCUS is not to consider it a replacement for formal diagnostic imaging. And we'll have some examples of how we use POCUS as a physical diagnosis tool and yet not have it replace formal radiological or sonographic studies. But really, it's a tool for a quick look at the point of care to answer clinical questions that matter as you're assessing your patients. I'm not going to go over these two very busy slides, but these are just excerpts from a recent article published at AFP this past March by a group of colleagues, one of the co-authors is a friend of mine, Dr. Chris Jonas, over at Uniform Services. It was a really nice review of point of care ultrasonography that's relevant for family physicians. And I'll point you to these articles that you can read at your own leisure, while Chris and his colleagues were able to provide pretty good numbers, and the numbers needed to treat for certain studies. And I think that for our colleagues who really liked to know the numbers, these are useful. This is useful data for you. So with that, I will kind of stop sharing, and I'm going to hand it over to Dr. Crutchfield to talk a little bit about some nuts and bolts, and hopefully we won't bore you too much, just a little bit of physics. Take it away, Anna.
Thank you, thank you. So I may be a millennial, but when it comes to this technology, bear with me here because this is my first Zoom presentation. Share screen, I guess I'll do that one. Okay, I guess maybe, let's go. All right, can you guys see it okay? I don't know what's happening.
We can see it.
Okay, great. All right, and then the view, nope, slideshow, there it is. Alrighty. So with that being said, just to go over a little history, myself, I love history, so I always like to learn about the history of things that I enjoy in the clinical setting. So ultrasound really dates back all the way to the 1700s when scientists discovered that bats used echolocation to basically find objects in space. That's how they got their bugs and things like that. Then in 1877, piezoelectricity, which we'll get into what that is later, but basically that was discovered by Pierre and Jacques Curie. Later on, they created the first transducer to actually locate the Titanic at the bottom of the sea. Then, you know, we started looking for tumors in brains. We started looking for, you know, different echocardiograms and things like that. So that was discovered in a shipyard, funny enough. And I believe I have a picture of some of that here. There it is, first pan scanner, 1957. And then we, of course, had the adoption of the ultrasound in OBGYN practiced by Dr. Ian Donald. In the 70s, color Doppler was created. So that was great for locating vessels. And in the 80s, 3D ultrasound was discovered. And then, of course, 1990s, we started using it for breast biopsies and things like that. So just to get into a little bit of the physics, what is ultrasound? Well, to put it simply, it's the sound waves that we cannot hear because they are too high when it comes to frequency. And so, you know, as we go on, you'll learn that different probes have different frequencies, but usually diagnostic ultrasound, the frequency ranges from 2 to 20 million hertz. So that's 2 to 20 megahertz. So that's far outside the reaches of our hearing. Ultrasound waves come from a vibrating piezoelectric crystal. So, you know, we talked about that being created. What exactly is piezoelectricity? Well, these crystals, when they vibrate, they allow electricity to be turned into ultrasound waves. Looks like someone's trying to get in. There we go. So they allow basically electricity to become ultrasound waves. From there, it goes to the object, bounces off the object, returns to the ultrasound probe, hits the crystals again, and then the crystal, you know, evaluates those ultrasound waves it gets and turns that back into electricity, and then that in turn goes into and turns into a picture on our screen. And so that's ultrasound, the magic or what have you of ultrasound technology. So to put it a little easier, the higher the frequency of the ultrasound waves, the higher the resolution you're going to get when it comes to your picture. However, this does decrease penetration. So the lower the frequency, in order to get some penetration, the higher the penetration goes, but you will lose resolution. So what does that mean exactly? So for things like superficial abnormalities, you're looking for abscesses, you're looking for cellulitis, things like that, we usually use the linear probe. The linear probe is very high frequency vascular probe. And so basically it has a lower penetration, so it can't go through a belly, but it can go through the superficial layer of skin. It shows very well images of nerves. It can show vessels. It can show, you know, the subcutaneous echo structure and things like that. The curvilinear probe is the classical ultrasound probe that if you ever did anything with pregnant women, you know that we use this to look in bellies. So it's low frequency, but it has high penetration, which is why we can use it to scan through people's abdomen. And basically it's used for fast scans, which is basically looking for blood in the belly in a trauma victim in the ER. You can use it for lung exams, locating the IVC, and other things like that. Phase array, so that's the cardiac probe. That's usually going to be the probe you use for any echocardiogram. It has a higher penetration, but it's about mid-frequency. So it's not going to penetrate very deep, but it will give you fairly good quality of your picture. And again, you can use it for these modalities below. And then you have your endocavitary probe, which is, you know, commonly called the vaginal probe. And it has a pretty broad range of frequency, and it's usually used for endovaginal or endorectal exams. And you can actually use the endocavitary probe and see quite well a very tiny fetus before you can see it on with the curvilinear. So just a little basic vocab before we get going any further. You'll need this in a little bit. Basically, we have 3 different terms. You have anechoic, and meaning without. So without any whiteness, so it's black basically. And so anechoic structures appear black, and usually they're either fluid filled with blood, or they could be fluid filled with serous fluid, like an cyst or things like that. Then you'll have your hypoechoic. So it's a little bit darker, but it's not anechoic where it's lacking any brightness at all. So you have your anechoic structures, and usually those are lymph nodes, those are tumors. Finally, you have your hyperechoic, so hyper bright. So your hyperechoic structures usually are fat tissues, like I think this right here looks like a lipoma, if I'm not mistaken. And also hyperechoic areas can be like things like the surface of a stone. And so that's kind of what you look at right here. You have your hyperechoic. Isoechoic is just gray. So if you ever hear that term, that's what they're talking about. You have your hypoechoic and then your black anechoic. And so let's talk about some cases. So I just saw this my first week. As most of you, if you did not hear, I just started as an attending, and I saw this woman the first week I got here. She's a 49-year-old female presenting to my office due to a rash that developed after she had a bug bite 2 days ago. Obviously, she believes that just like her diabetic grandmother, she has cellulitis and she needs antibiotics. Her symptoms are itchiness, mild tenderness, redness, as you can see, and a little bit of swelling. You examine the area and you note the picture right there, a bit of urticaria type of picture, looks like a hive basically. You're like, okay, basically the question is, how can you put the patient's mind at ease while simultaneously increasing her confidence in your clinical skills? And it's great to have an ultrasound on hand for patients like this that want antibiotics, but you're like, this is not a cellulitis. There's no way, but just to make you feel better, let's look at it under ultrasound. And so normal subcutaneous tissue, when you put the ultrasound gel on, of course, it needs jelly or some type of liquid interface to get through. You have your epidermis, which is very hyperechoic, your fat, which is very hypoechoic, and then you have some fascial layers, which can also be very hyperechoic. And then you have muscle, and then more muscle that you see some striations in. And so I want you to really pay attention to this epidermis-dermis layer with the fat, because that's going to tell you if there's a lot of inflammation and signs of cellulitis. So what cellulitis looks like is what's called cobblestoning. So cobblestoning is basically where there's fluid in between fat globules that makes it look like a cobblestone street, sort of. And so when you see this, you say, okay, yes, this is cellulitis, something's going on, we need to get antibiotics on board. The good thing about it is, I don't know if you've been here, but I have, sometimes even if you do think the rash is a cellulitis, you're worried that it might be an abscess versus a cellulitis. And so you want to rule out, a fluid collection. And so you don't have to do an IND and put them on antibiotics. And ultrasound can help you delineate that. And so that way, if you miss an abscess, they have to come back and then you have to drain it and then, more antibiotics. And so it kind of expedites care. And so the patient doesn't have to come see you as much. When it comes to abscesses, so you see this in the subcutaneous space. And so you see the fat globules around here, and it's very kind of hyperechoic. It's a lot of inflammation in there, but then you have this hypoechoic structure in there with some debris in it, in fact. So you might even have some sebaceous material in there as well. Sometimes you'll see septations, which is great to know because, again, if you just, IND, poke the area, drain, you may need to actually probe inside the abscess to break up septations. Well, with ultrasound, you'll know if you have to do that or not because you can actually see the septations. So again, this is an abscess. The difference between an abscess and a cyst is a little bit more walled off. And so this is very irregular border versus when I see cysts, they're very, very well structured. I think I had one a while ago. There it is. Boom, cyst, very, very normalized border versus this thing is kind of irregular and kind of funky looking there. So that's what happened with that. Now also you can see some, it looks like my lights just went out. I haven't been moving enough. So I'm really catching the Halloween theme behind me. Sorry about that. Anyway, so this right here is a picture of necrotizing fasciitis, which you actually can tell on ultrasound as well. Necrotizing fasciitis, how that looks is, it has a similar look to cellulitis, but what you'll see here is what's called reverberation artifact, which is basically you'll have a bright line in the dermal space, like these little bright lines, and then after it, this shadowing effect with these little white lines that seem to repeat the white line above it. So white line, and then it goes down, goes down. And so that's reverberation artifact. That's a sign of gas. That's the same, if anyone knows anything about pulmonary ultrasound, that's the same type of reverberatory artifact that you actually see in A lines on your pulmonary exam. And so this is bad, this is gas, this is an OR visit. But thankfully you can tell that with the magic of ultrasound. So then we have, what did I do with this patient? I showed her her ultrasound. I said, hey, look, this is your ultrasound. Let's look at a picture of cellulitis on Google. And I was able to show her an ultrasound of cellulitis versus her ultrasound. She was very happy. She said, yeah, it's allergic reaction. And she received the topical steroids and the antihistamines with no argument. So I'm happy, she's happy, thanks to the magic of ultrasound.
Okay, so this next case is actually a case that I've seen. That's actually not a true picture of our patient, but bear with us here. So this is actually a scenario we frequently see in the office. So 40-year-old female on oral contraceptive pills, no other real significant past medical history. She comes in, to see you in the clinic. Of course, this is like your last patient of the day, maybe at 4 p.m., maybe second to the last. Came in for leg pain that she developed after taking a cross-country airplane trip, okay? So she comes in and she's concerned that she might have a clot or something like that. So there's a couple of different scenarios how this could play out, okay? So scenario one is sort of a typical situation that we often will encounter before we start doing POCUS, right? So to avoid an ER visit, the clinician decides to arrange for a stat outpatient Doppler at the hospital that's next door. So our clinic is located on the hospital campus. And thankfully, our hospital often does take outpatient visits to avoid an ER visit or other charges to the patient. So often we'll call ahead, we'll put the order, we'll discuss, and the outpatient radiology department will agree to do a quick Doppler for us. Now, of course, the patient walks over, takes a little time, gets registered, and completes her scan at about 5 p.m. Meanwhile, she's waiting at the hospital, waiting for the radiologist to do a wet read, who may or may not actually be there. And when the radiologist does the quote-unquote wet read, the radiologist then calls the physician on call, which in our practice is often one of the residents on call. Resident might be busy doing an admission, a couple of little phone tag back and forth. Meanwhile, the patient is still waiting for the results. She's already at the hospital, gets more anxious, and decides to go to the ER anyways. Scenario two, to avoid an ER visit, the physician at the office decides, I'm just going to do the scan myself, and you pull out the ultrasound probe. You've been trained to do 2-point compression, lower extremity DVT protocol, which we can talk about. And the scan is completed in just a few minutes. And I decided to be generous and put in 4:30 p.m. is when you complete the scan. But I will tell you that, if all goes well, you can complete a lower extremity DVT scan in 30 seconds, maybe 1-2 minutes tops, if you're well trained and you're comfortable doing it. Next slide, please. So here's an example here on the left side of the screen. You can see what we often look for. You can see that this is a view kind of up by the hip and the thigh. You can see this, the larger anechoic round structure there is going to be your femoral vein. And with compression, you can actually push down on the vein and collapse the walls so that the walls actually touch each other, what we often call coaptate the walls. Of course, if you can do that, that means there's nothing in the lumen. Contrast that to the image on the right side, where it's the same structure in a different patient. When you apply compression with the probe, you can see that you're unable to fully coaptate the walls of the vein. You can tell that even the artery gets a little bit squished, but the vein will not collapse. So even if you don't see echogenic or bright white material within the lumen, because it doesn't collapse, you can ascertain there's some reason why it's not collapsing, and it could just be hypoechoic or even anechoic clot. So now you raises your suspicion for a DVT. Next slide. So scenario 2, this is actually not uncommon in my clinic often. We'll actually diagnose a DVT on POCUS. It was highly suggestive and suspicious for a DVT. Little shared decision-making at the point of care, at the same encounter, the same visit. Talk about the pluses and minuses of different anticoagulation strategies, Coumadin versus more of a NOAC or DOAC approach. And then we just decide that we're going to go ahead and start anticoagulating. I still arrange for a formal Doppler ultrasound, usually either later that week or the next week, to do 2 things. One is that I'm not a vascular lab, and in order to provide a little bit more certainty in the diagnosis, we'll do a formal study. But 2, we frequently do get follow-up Dopplers anyways, in order to look for progression and to monitor how things are going with the thrombotic disease. And so again, really using POCUS at the point of care as a physical diagnostic tool rather than a replacement. And so efficient patient care with a pretty good patient outcome. So next slide, please. So for those who like numbers, this is just a real quick plug here. Tom Christ and his colleagues' study in 2010 looked at, in the ER setting, 2-point compression, which is essentially the very technique that I showed you in those examples, and found that of the clots that came into the ER, 30 minutes of training to almost 200 exams, pretty favorable sensitivity and specificity. Okay, and we can certainly talk more about it at the Q&A session, but definitely POCUS for the win. All right.
All righty. So again, hey, I'm the Halloween doctor. I'm still in the dark over here, but we're going to keep on trying to make you see the light of ultrasound. All right. So we have case number 3 here. Patient comes in with foot pain. So this is a 31-year-old. Let's see. Oh, someone may have a question. This is Dr. Elvarai Bonnie. I probably butchered that name. Someone has a question?
Yeah, I'm a 4th-year medical student.
Oh,
Elvira is my middle name. I'm from Italy, which is why it's a little weird.
that's all right.
Yeah, so question about the leg pain. So I actually happen to be on my ultrasound elective right now at Temple University. And one of the things that I found kind of variable was whether or not you look at both legs. And I was wondering, for you guys, do you look at both legs or only the one that's, I'm blanking on my words, the one that you're suspicious of for DVT?
Dr. Ho, you want to take this or you want me to get it?
I'll take it. I'll be happy to. I think certainly both are options. If somebody's only complaining of symptoms on one side and that's all you're concerned about, you can. I think I frequently do just unilateral scan. It wouldn't take much for me to scan both. If I were to find something that's a little funky looking, I'm not entirely sure, and I'm not that convinced it's a clot. And again, we're moving beyond the typical protocol. I might scan the other side. And that's one of the tenets I'll often actually bring up with POCUS in general, and especially musculoskeletal ultrasound. One advantage you have is that since you're doing it at the point of care, you have the luxury of being able to scan the other side fairly easily. So I think, so my answer is I usually just scan the side I have a question about, because again, it's about answering clinical questions, with the caveat that as needed, I will scan the contralateral side at libitum for fun. So, yep. Or as needed. So hopefully that answers your question.
And then I do have one other question about medications that you would prescribe. I guess I'm more familiar with the inpatient setting where you have the heparin bridge to Coumadin. So I was wondering how that works in the outpatient field, especially since for the DOACs, there's usually a high copay or they're not even covered by insurance.
Well, I think that you're going to find variable trends depending where you are in the country. I know that in our area, more and more payers are actually willing to pay for a NOAC or a DOAC as a first line and we're thankful for that. I will say that if I am, if the patient chooses a more traditional warfarin strategy, what we'll do is we'll start them on warfarin, but we'll also give them a prescription for, kind of a low molecular weight heparin that they can use sub-Q. We're also a little spoiled in that we have pharmacists in-house with us in our clinic. So you can actually ask them to do the teaching. Or what I frequently do is ask my nurse to do some sub-Q insulin sort of teaching for them to do, and they can demonstrate on like a little saline on a little syringe for them to practice. But yeah, I think those are usually my two strategies, but I won't belabor that too much more to keep us rolling here, but hopefully that was helpful for you.
Yeah, thank you.
All right, and just so you know, Victoria, I did actually have to scan a bilateral finger today. I had a patient come in and basically she was having issues where we were like, is this just a subcutaneous inflammation or is this actually a abscess? And so I scanned her and I saw a fluid collection and she was like, are you sure that's a fluid collection? I was like, you know what? Let's make you feel better about it. That's why God gave you more fingers. And so we ended up scanning multiple fingers and she saw that, none of my other fingers have that big black spot there except for this one. And so we ended up having to IND that and she felt better about it and everybody was happy. So let's see, case number 3. The patient is a 31-year-old female triathlete that's training for her first marathon. She presents to your office with left foot pain. She endorses turning her ankle just a little bit during one of her runs, but she was able to run through the pain. She went to an urgent care the following day, and they, of course, got an x-ray. She brought that to your clinic for you to examine yourself. Her foot has no edema, but her pain is re-elicited with walking and on palpation of the lateral border of the 5th metatarsal. So she shows you this x-ray, and this x-ray is negative. This is a normal x-ray. If you Google normal foot x-ray, this is what will show up. So then you move on. And so you say, you know what? Well, let's look at ultrasounding your foot and let's actually see the cortical border and see if there's a stress fracture present. And ultrasound does a great job of doing that. So here again, we have your hyperechoic epidermis, you have your hypoechoic subcutaneous fat, you have some muscle layers, you see all the striations. And then right here, you have bone. Bone cortex is very hyperechoic. And then after that, this shadowing is because the bone the ultrasound waves cannot go through the bone very well. And so it basically blacks out after that. And so you see here a normal, happy bone. There's no abnormalities there. But then when you're looking for a stress fracture, what you'll see is a disruption in this cortex. So you'll see a clear delineation disruption. And sometimes if you're wondering, is that a disruption? Is this normal? You can always look at the other foot just to see. What you also can do is see this hypoechoic fluid collection around it that seems to be kind of pushing away the muscle and the fascial layer. That right there is also a sign that this was indeed a stress fracture. And so instead of, putting her, in a boot and then, or getting another x-ray, giving more radiation exposure, things like that, because we all know sometimes stress fractures do not show up when you look the first x-ray. Usually even just a regular fracture can show up 3 days later. And so ultrasound, again, to save the day, you've diagnosed a stress fracture, you're able to put her in a boot, and she's thankful. You see her again in a couple of weeks, and usually 4 to 6 weeks, and you're able to dismiss her from the boot and all is well. So again, this was her. There's cortex abnormality or disruption in the cortex, and then you have this fluid collection around that abnormality. So that's kind of what that looks like. And again, great job for ultrasound, and it cuts down on the cost of medicine in general, because she would just continue to have some aches and pains every week because she's type A marathon runner. And so she would probably come back to you soon and say, I want an MRI. But instead you can tell her, this is what it is, you will heal and stop running. So go from there. All
right, well, this next case is a real patient of mine as well. And So this is, we all have these patients, but this is a patient, 67-year-old male, former smoker, history of hypertension, hyperlipidemia, which was well controlled and well managed with lifestyle changes and medication. No history of diabetes, but like many of our patients, I'll get around to it. Never got his AAA screening despite my efforts to check that box. And every year I would order a abdominal aorta ultrasound for the screening, but he just never found the time to get it done. Then he comes in to see me for acute, severe, low back pain, terrible back pain. You could barely even do a physical exam. You know, he really didn't feel like moving very much. He described it as sort of a pounding, low back pain that he just felt like he couldn't move, and thought that maybe it kind of wrapped around a little bit, but maybe kind of pounded through his abdomen. He wasn't sure, but he was just really uncomfortable. The exam was severely limited by pain and guarding. So the question is, you know, your little antenna come up a little bit. You know, do I send him for an emergent CT scan next door to the hospital? Or do I just take a quick look? Let's take a quick look. So next slide, please. And so I did a quick, you know, point of care ultrasound looking at his aortic, his abdominal aorta. And we actually find these findings here. And you can see that looking at the measurement that these are normal findings for an abdominal aorta. No real ectatic or aneurysm kind of finding. And so, you know, it looked pretty good. And these are just two examples. I was able to scan his entire aorta. He just really didn't feel like eating even that morning. So, you know, there wasn't a whole lot of bowel gas. So we actually got some pretty good views of the abdominal aorta. So I keep scanning. Next slide. And this is what we see. And you'll notice that on his left side of his kidney versus his right kidney, they look fairly different. And if you notice that, you can actually see that on the left side, you got the collecting system, and kind of that in the collecting system, you see these anechoic areas that are very ectatic and opened up. So you can see the renal pelvis is very ectatic and widened. And you also notice that some of the collecting system is actually kind of ballooned out a little bit. So we actually have mild, moderate hydronephrosis here on the left side versus the right side, which was a fairly normal looking kidney. So next slide there. So you can see that there was a big difference here. So no AAA, thank goodness, right? Left hydronephrosis and fairly tender to percussion in the left costovertebral angle. So the presumptive working diagnosis here was a stone, you know, a kidney or ureteral stone in this case. Plan was hydration, gave him a little prescription for tamsulosin, pain control, gave him a little strainer to strain his urine. I ordered a non-urgent CT scan, did not have to go to the hospital, which was actually done the next day. No ER visit, patient happy. Followed up in just 48 hours, was significantly feeling better. And again, was able to avoid the radiation and avoid the radiation immediately anyways, and was able to avoid an unnecessary ER visit. And of course, these days with coronavirus out, you know, in the community, I think that's just one less person exposed to COVID. So once again, POCUS for the win. This is just as another, just the more data for you guys that, you know, sensitivity, specificity for POCUS for stones is reasonably well. And I think the reason why it's low is because frequently you can have non-obstructing stones as well, and sometimes that won't necessarily show up as well, you know, as easily. But it's fairly specific when you can actually find hydronephrosis, especially when it's more than just trace. So again, I think that POCUS is fairly helpful in this setting as well.
All righty. So for all of those that love to do mission trips and things like that, this one's for you. So this is an actual patient of mine. As you can see, I kind of blurred out her face, but this was basically me, my third year in family in residency. And so you're a third year family medicine resident that has some, that has somehow finagled a 2-week global health rotation to Kibagor, Rwanda. Yes, I did finagle that. You are helping the general practitioners there with their day-to-day workflow when a 38-year-old female with no significant past medical history, presents to you due to missing her period for the past 5 months. She hopes that she is pregnant since she and her husband have been trying to conceive for the past 2 years. She denies feeling any kicks, but states that her belly seems to be getting bigger and she feels bloated. So again, we're in Rwanda. Sometimes you may not have an ultrasound, but if you have that technology, even if it's maybe from the 1990s, the fact that you have that technology puts you above most, because this was literally just kind of sitting in one of their storage closets, and I kind of fished it out and found it, and it was working great. So usually, again, we would use a curvilinear probe for this because, again, it has a low frequency, but it has a high penetration. And so first trimester ultrasound, usually all you'll see is the uterus, you'll see a gestational sac, and that's about it. If you want even better actual visibility for a first trimester ultrasound, you again want to try the vaginal probe instead of using the curvilinear. So then sometimes you'll see a little fetal pole, and it's just cute little baby fetus. Sometimes you can even see a little flicker of heart movement in there. And then second trimester, obviously the baby gets much bigger. And so you can see most of the baby, but then you go ahead and get to the third trimester, and all you see in the third trimester, I didn't even put a picture on there, but all you can see is like a random leg, a head, you know, that thing is stuffed in there tight. And so, oh, I moved. I moved to turn back on my lights. All righty. And so what did I find? So what you find using the hospital's only ultrasound is this. You find there is your uterine wall, and there is this very strange substance. It's like a starry sky, something like that may ring a bell. And you're like, what in the world? And so of course she's already gone and gotten her pregnancy test, and it was positive. And so you actually found a Hydatidiform mole during a mission trip in the middle of Rwanda. And so again, ultrasound for the win. Again, this is real picture from their actual scanner. I took it with my cell phone back then, but yeah, so if anything, this really should tell you ultrasound has a plethora of things that it can diagnose. I mean, we've gone over AAA. We didn't even get to the lung exam, the cardiac exam, the MSK exam. Of course, when I was in residency, I used ultrasound for femorals. I used them for subclavians and internal jugulars. I did paracenteses. I did thoracenteses, soft tissue abscesses. I actually was able to pinpoint where it is, poke it right there versus having to make a big longitudinal scar when doing INDs. So it's really been great for me to actually learn this. So final thoughts in general, POCUS, also known as point of care ultrasonography, has become the standard practice in obstetrics, emergency, and MSK medicine. POCUS has a high accuracy rate for diagnosing DVT, AAA, pneumonia, and acute decompensated heart failure, plus many other things. Protocols usually answer a specific question. So again, you're in your clinic. Is this an abscess or is this a cellulitis? Which one? So it really helps to guide treatment. There is a mounting evidence that POCUS can help decrease the cost of care while improving patient access and care and safety. Let's see, POCUS can serve as an initial triage tool to determine if patients may need more advanced imaging. Like, you know, you see the hydronephrosis, and then you're like, okay, let's get a CT, let's find where the stone is and go from there. Maybe it wasn't a stone, maybe it was a mass this whole time, you know. So it's great to have that tool just to kind of lead you to where to go next when you're triaging. It's also used on inpatient. I used it tons on inpatient to actually determine fluid resuscitation by looking at the IVC. If this person, you know, is fluid depleted and they're a heart failure patient, do I need to give them 1 liter? Should I stop the fluids? Are they overloading? So it's great to use for things like that. I've even used it in codes to see if there was any heart motion while we were doing the code. It doesn't get in the way. Our ICU doctors used it constantly in our codes. And it's being integrated in medical school, as we all know, residency curriculums. The AAFP recommends ultrasound, and it's just really becoming a more standard practice in our field as well as everywhere else. So I'm glad you guys were able to put up with my corny jokes and my lights going out. Any questions? Dr. Ho, did we have any questions?
I think there was one question from Victoria about using POCUS for stress fractures, the different views. Do you want to take that, Anna, or you want me to take it?
Sure, I can take it, even though you are the MSK expert.
Go for it. Go for it.
Well, I guess what, Victoria, what you're mentioning, and correct me if you're wrong, is basically how do I put the probe in relation to the bone? Is that what you're asking?
Yes. Yes. So during my rotation, the one thing that they're a little weak on was describing what to do for the different MSK exams, especially since it changes depending where you are. So especially like with stress fractures, I'd love to know what the gold standard is.
All right. So lucky, we have here a probe. This is the linear probe. Even here we have a nicer probe here that can show way more details for very small parts like fingers and things like that. And of course we have our curvilinear. But for stress fractures, especially for the patient that we talked about with that 5th metatarsal stress fracture, I would use the linear probe. And what I would usually do first, if you can picture this being the 5th metatarsal, I would put the probe in plane or longitudinally across the bone. And that way until I get a nice straight line, really outlining that cortex. And you see it and you're just like, oh, there might be something there. Let's scan back and forth, back and forth. Yeah, there's definitely something there. And then you can even turn it transverse or out of plane, where you're basically looking onto the bone itself. But the pictures that we showed you were all in plane. And so that basically creates a straight line of the bone, basically when you're out of plane, that creates basically you kind of looking like this, and the bone just looks like a little C. You see a little bit of epidermis, dermis, muscle, and then you see the very hyperechoic white line, that's the C, and then the shadowing after it. And so that's basically kind of what you would see out of plane versus in plane. Again, you get the nice linear cortex. Does that make sense?
Yes, it does. So then you would do the in-plane view, and then I'm assuming you would clip it kind of going along the bone, and then you would sweep side to side where you find the fracture.
So where I would basically take a picture is whatever looked abnormal, I would take a picture of it. If you wanted to compare the abnormal side to a normal side, you can take as many videos as you want. The big thing for this is if you're documenting this, you definitely want to get the abnormality and then go out of plane, you can get that same abnormality. That's usually the standard of what you want to do when looking at something abnormal on ultrasound. And correct me if I'm wrong, Dr. Ho. Does that sound about right?
Yeah, that's exactly right. I think that that was a great review of some general concepts with looking at osseous injuries. And so, yeah, but I think the last thing I'll mention just in general for musculoskeletal ultrasound is that there are different views for different structures, and they do vary. The two resources I'll point you to when you want to learn the standardized views, because they are standardized actually, there's two. In the US, the AIUM, the American Institute of Ultrasound Medicine, has very specific guidelines as to the standard views for certain studies. And then the other, which frequently used abroad, is the ESSR. That's the European Society for Skeletal Radiography. So I'll point you to those two if you want to know the actual specific views for various parts of the body for MSK. I see that, let's see, looks like Javier has a question.
Thank you.
Yeah, you're welcome. You're welcome. Looks like Javier has a question as well. So go ahead.
Yes. Hi, my name's Javier. There's been many times I've heard about point of care ultrasound. I get really excited, but then I feel like in the same breath, I hear that there were a lot of false positives in a particular way of using it, or this mention about how it's very user dependent.
Mhm.
And so what I was wondering, particularly I heard one that was regarding the screening for breast cancer. Now, aside from that example, what I'm curious about is since you published several articles which actually show fantastic specificity, what do you think are some ways that sort of make the point of care ultrasound a better tool than maybe it seems, to reduce false positives? Is that accomplished through better training, better technology? And also, what are the limits of that? Like, what cannot be evaluated well and needs to be followed up with something else?
I think that's a great question. Maybe I'll take first stab at it. I think that you've already given me most of the answer already. And that is probably one of the biggest limitations for ultrasound in general, and not just POCUS specifically, but any ultrasound, is that it is operator dependent, meaning that whether it's the sonographer getting the image, or in this case, the sonologist, which is the clinician getting the image, is that your skill with it is going to influence the sensitivity and specificity significantly. So it really behooves you to your comfort level and training and experience. But at the same time, that same kind of reliance on the operator is also something you can take advantage of when it comes to increasing your sensitivity and specificity. Recall that most diagnostic imaging is read in isolation, unfortunately. And this is why radiologists are always asking for more clinical information. As the clinician, you have that already built in. And if you have enough comfort and skill and practice using the ultrasound, coupled with the clinical information that you have as the treating clinician, that is how you can increase your sensitivity and your specificity, and often to the point where you can actually do a better job than so-called gold standard. Just one quick example, I have an orthopedist colleague right next door who will refer his patients to me if he doesn't get the information he wants out of an MRI. He wants my ultrasound. It's the tiebreaker. It's actually higher resolution. Now you furrow your brow because we are often taught that MRI is the gold standard. Head to head for shoulder rotator cuff tears, ultrasound has superior spatial resolution than MRI, but it's operator dependent. So that's always the caveat. So if you have the experience and the skills, the tool is only as good as the person wielding it. So I think that hopefully that answers your question a little bit. And it is one of the biggest weaknesses to ultrasound, but at the same time, I think it's also one of its greatest strengths.
Thank you. That was an excellent answer.
Thank you. And I'm not sure if you have anything else to add to that.
I guess just that during my training, since I'm fresh out of training, I'm kind of similar to where you were. When I was in residency, we basically went around the hospital during our ultrasound. We had a designated month of ultrasound. We went around the hospital. We had to get 5 scans a day. And if we found anything weird looking, concerning, we would tell the inpatient team and they would get a formal study, and that would either validate our skills or say, ooh, I need to read a bit more. But of course, before even getting let loose into the hospital, we did tons of videos, we did tons of scans on each other, and we even had a mock patient come in and we scanned all of their viscera in order for us to learn from, and then they let us loose in the hospital, and that's how you get good, just scanning and scanning and scanning. So, practice makes perfect. I know everyone's heard that, but it's really true when it comes to ultrasound.
Thank you. That's really reassuring to hear.
We have just one minute remaining.
I'll let someone else ask a question then.
Our last minute, any other questions?
I have a last minute comment. Being married to a wife who's had numerous kidney stone attacks, we have learned over the years that the other treatment is beer.
It's the cure for
it actually helps. You won't find it in the medical book.
I think that's great. It's pushing fluids, right?
Absolutely, absolutely, in dilating the structures.
I don't know, Dr. Crutchfield, will you write me a prescription for beer?
I'm on it.
Okay, so we're bring things to closure. Thank you, Dr. Ho. Thank you, Dr. Crutchfield. Appreciate all the folks who have joined in, and we're going to close the session at this point. Good night, all.
Guys.
Good night. Thank you.
Thank you. Bye.